Thank you all for being here. We're going to go ahead and get started. And our first presenter will be David Musoke from the Macarrera University School of Public Health in Uganda. Thank you, David.
Thank you very much, Annie, and good morning, good evening to you all. So in this work that I'm sharing, we conducted a systematic review that was aimed at summarizing evidence on integrated malaria prevention in low and middle-income countries. And just for you to note that integrated malaria prevention in our context is use of several methods to prevent malaria at households in a holistic approach, as opposed to using a single or no method at all. And this has come from our vast work on doing research on using various methods to prevent malaria. So this systematic review was able to review vast literature from several databases, including PubMed, Google Scholar, Embase, and many others. And this particular systematic review in this presentation shares evidence from 64 articles. And in summary, this study was able to find out that actually a good number of studies were using 2 or more methods to prevent malaria at their households. Many of them are using 2, and only a few are using 3 methods, and not many studies used more than 3 methods. And the main methods that were used were, as you would expect, insecticide-treated nets, particularly long-lasting insecticidal nets, as well as endozoidal spraying, but others used IETNs as well as mosquito repellents. For the other studies that used methods beyond these, others used housing improvement, others were using insecticide sprays in their households, whereas larviciding was also used to some extent. Other than the occurrence of malaria, the secondary outcome was the presence of mosquito in houses, and most of these papers indeed confirmed that in studies where 2 more methods were used, there was reduced occurrence of malaria compared to studies that used no method or a single method. And that also relates to the presence of mosquitoes. So mosquitoes were less in studies which used 2 or more methods. So in conclusion, the evidence we generated indeed confirms that a number of studies have been able to conduct research using 2 or more methods to prevent malaria in their households. And also the evidence coming through suggests that those studies that use multiple methods indeed demonstrated reduced occurrence of malaria, as well as reduced presence of mosquitoes. And for that reason, we believe that there's more need to have further evidence on using multiple methods to prevent malaria, because as many of you would know, the core prevention methods have really been mosquito nets and endozoidal spraying in many countries. But we believe that other interventions could actually be put in place holistically to reduce on the burden of malaria in our developing countries, as well as other countries around the world that have malaria as an endemic disease. Thank you very much, and happy to take on any question or comment.
Thank you, David. That was excellent. We're happy to take questions either in the chat or if you would like to unmute. So please go ahead with any questions. David, I think I have a question while others may be thinking. You mentioned housing improvements as one of the additional methods, and I wondered if there were types of environments where those were more common, as I think we hear anecdotally that housing improvements can really reduce the number of mosquitoes and exposure to mosquitoes, but it's one of the more challenging interventions. So I wonder if there were patterns to where you saw those being deployed.
Right. Thank you, Annie, for this question. In most of the studies that had housing improvement as an intervention, this intervention was actually carried out in rural communities, mainly because it is in these settings that they have very poor housing. And therefore, many of the experimental studies were able to implement housing improvement, particularly screening in windows and vents, improving the doors so that there's no spacing at the bottom, but also blocking any cracks in walls to prevent mosquito entry. So most of these studies focused their research in the rural communities in low and middle-income countries, where malaria, of course, is prevalent, but also where there's poor housing structure. And this, I believe, was a good approach to have that evidence that actually when you compare houses that have not had any improvements with those that have improvements, added to any other method, whether sleeping under a mosquito net or having individual spraying, that actually improves the protection against getting malaria.
Yeah, that's very true. Thank you for pointing that out. And thank you for your presentation, David. We're going to move on. And Benjamin Rice will be presenting. Benjamin is from Princeton University in the USA. Benjamin, please go ahead.
Thank you, Annie. Hi, I'm Benny Rice. I'm a postdoc in the Department of Ecology and Evolutionary Biology at Princeton University. It's a privilege to discuss our team's work on a cohort study in a high prevalence district in Southeast Madagascar, the Mananzari cohort study. First, I wanted to recognize my colleagues, especially Doctors Radhi Sua, Andrea Noeli Vululuna, Meheri Rebalia, as well as Joe Lewinsky and Jim Hazen at CRS. I also want to take a moment to thank the members of the local community who participated in this project and the entire Mananzari research team that makes this work possible. As seen in the lower left in this small map, malaria prevalence is highly heterogeneous across Madagascar, with discontinuous areas of much higher prevalence. We are interested to zoom into one of these areas of higher prevalence, one of these higher prevalence districts, and ask what drives variation across space and time at the local scale. In particular, we have a new and growing interest in the role of extreme weather events, in this case, tropical cyclones, and altering incidence trends. And finally, we're interested in testing new ways to use genomic surveillance at more local scales in light of the high and highly variable prevalence within regions of Madagascar that we've observed. In the middle here, in terms of methods, we launched an open prospective cohort study in 2021, where we've been following 500 households evenly distributed across 10 randomly selected rural coastal communities in the Mananzari district. And the photo shown in the middle, I'm showing one such study community. In terms of preliminary results, here on the right, I'm showing to the right, prevalence by RDT over time since the baseline sample in July 2021. Note the large variation in prevalence among these nearby communities, where prevalence ranged from 15 to over 60% at baseline, and the sort of downward seasonal trend we've observed since then. Monitoring is ongoing to see effects of the two large cyclones that hit southeastern Madagascar in February 2022. We're yet to see any sort of altering effect at this point, but that research is ongoing. I'll conclude there just to say thank you to the organizers, and please contact me at the email shown below if of interest or any interest in collaborating. And thank you.
Thank you so much, Benny. That's very interesting. I'm always fascinated by spatial temporal methods. Are there questions from anyone in the audience on Benny's work?
I have a question.
Go ahead, Michelle.
First of all, thanks for your talk. Super cool. I was just wondering if you could say what the 3 time points on your plot on the right refer to.
Yeah, so this started in July 2021, and baseline sample took about 2 months, and then it's been bi-monthly sample since then, and this is up to March. So roughly every 2 to 3 months for the study sites. And I can get you those more specific dates. This kind of goes from sort of like the colder, drizzly season in Mananzari through the sort of cyclone season with
So
ongoing data collection. Yeah.
So is time 1 like July 2021? Is that what that means?
Right, July 2021, and then the baseline took a couple months, so maybe until September 2021.
Okay, cool. Thank you.
Yeah.
Great, thanks for that question. Are there any other questions?
Benny, this is Bill Moss. Are you using any remotely sensed data to assess ecological factors that may be associated with this heterogeneity?
We are. So by eye, the study areas look very similar. They're kind of sandwiched between inland freshwater and coastal open Indian Ocean. By eye, they're very similar with sort of a similar contribution of different freshwater and saltwater habitats around them. But we are using satellite imagery and then working with some climate folks to look at how those cyclones alter that local landscape. Because sort of by random chance, the first year of this project coincided with the unusual amount of cyclone activity.
Great, thank you.
Wonderful. So we are going to move on. Thank you very much, Ben. And next we have Susan Rumisha from the National Institute for Medical Research in Tanzania. Susan, please go ahead. The floor is yours.
Hi, everyone. So my name is Susan Rumisha. I'm a researcher from the National Institute for Medical Research in Tanzania, but I'm also a postdoctoral researcher at Malaria Atlas Project in Perth, Australia. So I'll present this work on behalf of my colleagues. It's the findings from a study that we did in Tanzania, where we assessed the role malaria play in the mortality caused by HIV/AIDS and tuberculosis in the hospital setting. So what's the story here? So the three diseases, HIV, tuberculosis, and malaria, famously known as the big three, they still cause significant morbidity and mortality in most countries in sub-Saharan Africa. However, these diseases, we know that they are interlinked. For example, people living with HIV are at higher risk of getting and dying from TB than those without. HIV also increases the risk and severity of malaria infection, and it's at increased malaria-related deaths. But also we have studies that show that malaria could impair TB containment and increase mortality of TB patients. But also the immunosuppression that is caused by HIV and TB may result to other severe complications such as anemia and also pneumonia, which when these are now comorbidities intertwined with malaria, they increase more even the risk of dying even further. So what did we do? So we designed a nationwide study and collect mortality data from 39 hospitals for a period of 10 years, that's between 2006 and 2015, where we captured about 250 total death records. About a quarter of these deaths recorded at least one of the big three as an underlying cause of death, of which more than half of those reported malaria. So we extracted a subset of diseased individuals where underlying cause of death was HIV or TB. Then we split among those that recorded malaria and no malaria as a comorbidity. Then we assessed how presence of malaria on HIV/TB deaths changed the odds of different age categories. Then we went further and assessed also impact of comorbidity with pneumonia and anemia. So what does this data tell us? One, what we see that presence of malaria, first it doubled mortality in these patients and it affects more children between 0 and 4 years old. Here the reference group is over adults over 60 years. Second, the presence of pneumonia, it shifts this risk over 3-fold in adults. And when you look at adding anemia, it shifted the risk up significantly in children between 0 and 4 years old. Further analysis is still ongoing for this study, but these preliminary findings, they demonstrate already that presence of malaria, it alters the odds of death in different age groups, and probably proper management of malaria and other comorbidities in immunosuppressed patients may improve quality of care in hospitals. So that's it, and that's my email down there. And if I'm happy to take any questions from the audience. Thank you.
I have a question. Super interesting, Susan. I was wondering about the case definition for those 57% that reported malaria, if that was determined in hospital, and if so, like based on what kind of test?
Yeah, so this because it's a hospital setting, so these are medically certified deaths, which are done by physicians, and they are using ICD-10 coding classification to a certain cause of death.
Thanks.
You're welcome.
Thank you very much, Susan. We're going to move on now. So next we have Tobias Holden from Northwestern University in the USA. So Tobias, please go ahead.
All right. Thanks, Annie. I hope everyone can hear me. Like you just said, I'm Tobias Holden. I'm a PhD student at Northwestern in Dr. Jillian Jaredin's lab. And today I'm going to share some of our ongoing work toward recalibration of a mathematical model of malaria transmission with parasite and infectivity data from Burkina Faso. Why do we want to do that? A little bit about the motivation. We know that in endemic areas, chronic asymptomatic infections are a major part of the malaria infectious reservoir. And we think of these as cases where the infected individual has sufficient immunity to decrease their parasite load and control their symptoms, so they may not seek treatment, but they may still carry the sexual stage gametocytes that are required for continued transmission. And there are a number of interventions that have been trialed to identify and treat asymptomatic carriers, but these clinical trials are usually at very specific or at small scales and in specific contexts. So for asymptomatic screening and treatment, as well as many other malaria interventions, we use mathematical models to predict the impact of these interventions if they were deployed more broadly. But to do this, particularly in the setting of an intervention that's aiming to detect and treat asymptomatic infections, we need our math model to accurately capture the key relationships between how many parasites someone has, how many gametocytes they make, how infectious they are to mosquitoes, and whether or not they would have symptoms. So our overall goal was to recalibrate an existing math model using longitudinal data from a high transmission setting. Moving to the bottom left, the reference data that we used to calibrate our model was from a study known as the INDI trial in the Sapona Health District of Burkina Faso that covered two wet seasons and an intervening dry season for a period of 18 months and collected data on parasitemia, gametocytemia, as well as infectivity to mosquitoes through feeding assays and symptom status. We also have information from that study on the seasonal mosquito counts around each household and the self-reported use of interventions like SMC for children or ITNs in the household. The math model that we're updating is known as EMOD, and there's a very small, schematic of how the model sort of works in the bottom left, but basically we mechanistically model things like the vector life cycle, vector and human interactions, and then this within host component that governs parasite dynamics. So the first thing that we did in the top right was make a spatial model at the study site with households grouped into these 1 kilometer square grid cells. And this is just an example of the map with no sort of other data shown. The small black dots are households. There's hard to see red H's for nearby health facilities. And we can determine the relative transmission rates between these cells based on the mosquito counts we have and the coverage that was reported in the study surveys. We have some other methods that we use commonly to calibrate the seasonality of malaria incidence and the overall transmission intensity. And this is what's been done so far for this study. I'm going to wrap up just with this last box since I know I'm running out of time. The next steps that we plan to do, or the real meat of the work, is in recalibrating that within host component or the parasite dynamics to the control arm of the study where subjects were kind of under standard of care. The main targets there are fever prevalence as a sort of conduit to symptom status, parasitemia and infectivity. We have some new parameters under calibration. The really nice thing at the end is that we hope with a recalibrated model, we have a system that's better able to study the impact of this asymptomatic screening intervention, both first by validating the effect size that was seen in the intervention arms of the trial, and then by exploring the impact of either targeted intervention, seasonal timing, different coverage levels, et cetera, on transmission reduction if this intervention was deployed over the whole health district instead of just in some households. If you have any questions, I didn't put my email here, but hopefully Annie can maybe put it in the chat for you all to see. It's just my first name, Tobias, my last name, Holden, at northwestern.edu. Thanks.
Thank you, Tobias. We have time for one quick question if anyone would like to ask one.
I have one, Annie, if that can go.
Go ahead, Bill.
Tobias, thank you. I'm so glad to see results from the INDI trial. We had hoped to do this and be part of this in southern Zambia. But my question is, we heard from 2 ICEMRs earlier today, Malawi and Uganda ICEMR, that showed that it was really the school-age children, the asymptomatic school-age children who appeared to be the major age group that's contributing to this ongoing transmission from asymptomatic carriers. And I just wanted to know if your model captured that age structure.
Yeah, so that I didn't share here, but I hope it's okay that I'm saying, I think that a similar finding is coming out of the preliminary results from India and Burkina Faso, that 5 to 15-year age group. I didn't mention it here, but all of our calibration targets are also age stratified. So we will hope to reproduce that bigger contribution from the school-age children.
Great, thank you.
Yeah.
Thank you so much. So next we're going to move to Michael Bride will be presenting on behalf of Bolanle Olapeju from Johns Hopkins Bloomberg School of Public Health in the USA. Go ahead, Michael.
Thank you, Annie. So like you said, my name is Michael Bride. I'm a senior research data analyst at the Center for Communications Programs in the Bloomberg School of Public Health. And my title is Psychosocial Factors That Influence Prompt Care Seeking for Fever in Malawi. So all treatment and services for malaria for children under 5 is provided free of charge in Malawi, but there are still significant delays. As few as 30% of children under 5 seek care within 24 hours, which is imperative to be able to treat malaria as soon as possible, to be able to be diagnosed and treated. So we conducted a study called the Malaria Behavior Survey in Malawi. It was a national and regional level survey that looked at all sorts of malaria behaviors. And from that, we took a subset of 913 female caregivers whose child had a fever in the past 2 weeks. And we took all the relevant variables pertaining to care seeking, and we applied the 3 delays on it, which is the first delay is deciding to seek care itself. The second delay is being able to go to a facility or qualified provider. And then the third delay is that care itself. So we took all our variables and we we stratified them we grouped them by the 3 delays model. So the first delay, things that would be like perceived susceptibility toward the malaria. Do they think they can get it? Do they think it's severe? The second delay was more like proximity to health facility. Do they feel like they have the funds to be able to do it? Do they have self-efficacy to do it? And the third delay was, how do they perceive they're being treated at a health facility? Do they think that they have the medicine needed? Things like that. So we ran several logistic regression models based on the individual factors themselves and as composite scores for each delay to look at what had the most impact. And what was interesting was that it was mainly psychosocial factors, not structural, and it was mainly the first delay. So we had 3 factors that were statistically significant from the first delay, and that was knowledge of malaria, attitudes towards care seeking, interpersonal communication. And then the second delay, we had knowledge of when to seek care, but this is kind of skewed because it was very prevalent in our sample, over 90%. And then our one structural, which was proximity to a health facility. What does this mean? This means that we kind of have to not just think about structural problems when we're trying to devise interventions to improve care seeking. We need to think about psychosocial factors. People need to want to seek care. People need to know that they have positive attitudes. They think that seeking care is the right thing to do. So we need more interventions that are contextually relevant. They have to be able to be understood and applied to these people. And it also has to be disseminated through a mixed message approach. There's a very low amount of internet connectivity, very low amount of people with radios. So it's like making sure that we do a spread of different interventions that focus on these psychosocial factors aimed at improving improving people to decide when to seek care. The study could not have been done without the National Malaria Control Program in Malawi and the PMI, which was our funder. Now I'll open up to questions.
Thank you, Michael. Any questions for Michael? I was wondering, Michael, how was the data collected? Was this a survey that was done of individuals who were seeking care, or was it done actively?
So it was a national level survey throughout every region of Malawi. It was just an interview, so a cross-sectional study. And it was just anybody that I clustered sampled, but like anybody that was in it, and we'd interview. And so the real sample size was around 4,000 women or something like that, but we only had 913 that had a child with fever in the past 2 weeks. But it was everything. We talked about IPTP, going to antenatal care, sleeping under a bed net, everything.
Okay.
It's a big survey.
Was it embedded in the National Malaria Indicator Survey or a different survey?
It's a different survey that was actually done right at the same time as us, though. The mix was done like 2 months before us, actually.
Okay. Wow. Great. Well, thank you so much for your presentation. We're going to move on to Michelle Evans. Michelle is presenting to us from the Institute of Research for Development in France. So Michelle, please go ahead.
Thanks. Hi. So I'm Michelle. I'm a postdoctoral researcher at the Institute for Development Research. And my talk follows very nicely from Michael's, because today I'm going to talk about some methods that we're currently using to try and correct for under-ascertainment bias in malaria data. And this is a project that's in collaboration with a health system strengthening NGO called Pivot, that's based out of a health district in southeastern Madagascar. So we all know that the cases that make it into the case surveillance system are really just the tip of the iceberg, and that financial, behavioral, or geographic barriers can prevent many symptomatic malarial cases from seeking care. And what this means is that the case data that we often use for fitting models or evaluating interventions can be really biased. And this is definitely the case where we work in Ifanadine in southeastern Madagascar. Ifanadine's a really rural district, and most transportation is non-motorized. And so you can see on this map on the left that there's people that live over a 5-hour walk from their nearest health center, and most people are living at least several hours. And so the big problem is that we can see that this spatial pattern repeats in our map of malaria incidence on the right. And so the data that we get through the system is affected by this non-random spatial pattern in under-ascertainment. So you can see that those areas that are closest to the health center, represented by those little crosses, have much higher incidence than areas that are further away. And this is a clear example of a geographic barrier to healthcare. So we developed a 2-step method to help correct for this bias in malaria case data. The first step involves calculating an estimated healthcare utilization index that we do using a method known as the floating catchment area. So this is kind of like the gravity model that you might remember from high school physics. So basically each health center has an attractive force that's a function of its mass or the services it provides, like the number of beds or if fees are reimbursed, and then the distance to a village. And then the expected healthcare access of that village is the sum of all of these attractive forces of the nearby primary health centers. We then use the inverse of this healthcare utilization index in a benchmark multiplier so that those villages with the lowest access receive the lowest correction to their raw case numbers, and those villages with really high healthcare access don't receive any correction at all. And you can see this figure on the right that shows the distance to care relationship of malaria incidence before and after correcting the data. And you can see there's this really strong exponential decay in the unadjusted data set as you get increasing distance to the primary health center. But when we adjust the data, this disappears. And I don't show it here, but we also verified the accuracy of these adjustments by comparing the adjusted data with malaria prevalence data from a longitudinal cohort survey. So we think this is a pretty promising method for dealing with poor data quality that's common in rural health districts, and that it can be applied both to malaria and other infectious diseases. And we're actually working right now on an R package to develop this so that other people can use the method, either to calculate their own healthcare utilization indexes or to correct their own data. And with that, I'd like to thank the other members of the research team, both at Pivot and IRD, and the residents of Ifanadine for their contributions to this project. And I think there's time if anyone has any questions.
Thanks, Michelle. I'm glad to hear there'll be an R package for it. This is exciting. Are there any questions for Michelle?
Michelle, I have a question. This is Matthew Ippolito. Hi.
Hi.
You know, are any of the metrics that are reported by WHO or CDC or anybody else, are they ever corrected for under ascertainment that you're aware of?
Like the metrics that are aggregated up to like the national level or something like that?
Yeah.
I think the case metrics are not, but I know at least for malaria, a lot of that data kind of comes from like the Malaria Atlas project and things like that. And I think in that there is some correction that's done because it's actually fit to prevalence data from like active surveillance. And so you don't have this problem as much because then you're going out and sampling people. Yeah.
Can I get one question in, Annie?
You can make a quick question. Yes, please.
Yeah. Michelle, very nice. I wondered if your model accounts for temporal changes in under ascertainment. I'm thinking particularly seasonal changes with rainfall.
Yeah, so it does. We, in a fairly simple way, we just fit a sine curve. So there's kind of a complex model fitting that I could not fit on one slide. But we do account for both like annual increases in access to care as well as like a seasonality.
Great. Thank you so much, Michelle. We're going to move on to the next presentation. Sarah Hill from the Johns Hopkins University School of Medicine will be presenting next. Sarah, please go ahead.
Hi, good afternoon, everyone. So I'm excited to be here today to talk to you a little bit about malnutrition and malaria outcomes. So the impact of acute and chronic malnutrition on malaria is still debated, even though studies have dated back nearly a century. Some research suggests that malnutrition is associated with a higher risk of malaria. Others say no differential risk, and others suggest a protective effect. And this discrepancy can partially be explained by differences in how nutrition status is measured, as well as differences in malaria outcomes. And most studies utilize clinical malaria or parasitemia as the outcome measure, but few studies have reviewed the impact of malnutrition on gametocytemia or recurrent parasitemia. So this study was a secondary analysis on data from a randomized controlled trial in Zambian children with uncomplicated malaria. In the original study, 182 patients were treated with 2 drugs, and they collected height, weight, and age at the beginning of the study. And parasite and gametocyte density was measured subsequently, along with reinfections. Height for age scores less than -2 were considered stunted, a measure of chronic malnutrition. Weight for age scores less than -2 were considered underweight, which is a composite of acute and chronic malnutrition. And weight for height scores less than -2 were wasted, which is a measure of acute malnutrition. And we use Kaplan-Meier and Cox proportional hazard ratios, as well as multivariable linear regressions to assess the relationships of these variables. So of the 182 children enrolled, 83 were stunted, 20 were wasted, and 35 were underweight. And we found that children who were underweight, or those who had acute malnutrition, had a higher gametocyte density compared to those without, while children who were chronically malnourished did not have a statistically significant difference in gametocyte density. It was found that underweight children had a median time to recurrence 1 week earlier than those with normal weight, and underweight children were 81% more likely to have a subsequent malaria infection than those with normal weight. And children with acute or chronic malnutrition did not have an increased risk of recurrent parasitemia. So overall, I think the results of the study show an association between underweight and stunting on gametocytemia, as well as underweight on recurrent parasitemia. And the observed association between gametocytemia and acute malnutrition may reflect a longer duration of infection and short-term weight loss, because gametocytes are the asexual parasite stage and mediate onward transmission of the disease. And overall, just providing evidence that nutrition status may reflect overall immune health. So happy to answer any questions.
Thanks so much, Sarah. Are there any questions for Sarah? We have time for a few questions. David, you have your hand raised. Please go ahead.
Yeah, hi, Sarah. Very nice study and really convincing results. Obviously, it's a fairly small study, but are there any hints of any signal if you stratify by sex or by age?
No, I don't believe so. We have controlled for it as a potential confounder, but I don't believe we've stratified at all. As you said, it is pretty small.
One might imagine a bigger impact on stunting and on infants, but you just have so few infants, it's hard to actually see the numbers.
Yeah.
Thanks. Nice study.
Thank you.
Susan, do you have a question? Please go ahead if so.
Thank you, Sarah. That was beautiful. I just want to hear your opinion on some thought that just crossed my mind as you're speaking, because those kids who are wasted or they are malnourished and they have the gametocyte, sometimes it's also about their socioeconomic status, because they have sometimes gametocyte because they cannot be able to seek care. So they stay at home with the malaria. So I don't know if you managed to look at that in the mirror of the socioeconomic status of where these kids are coming from.
Yeah, I think that's it. That's a really great point. And I think that is one of the limitations of this study, just because the children who were presenting were already infected. And so there's a little bit of a bias there because they're already presenting to the hospital. So yeah, I think that would be an interesting thing to look at, definitely.
Thank you.
Great, thank you for the questions, and thank you, Sarah, for the presentation. I'm going to swing back to the top of our agenda. Abdul, are you able to unmute and hear us? I know you were having connectivity issues earlier.
Yeah, my connection is good now.
Okay, great. So I'm going to go ahead and jump to your presentation. Okay, wonderful. So Abdul-Razak Issah from Fountain of Blessings for Nations in Ghana will present to us now. Please go ahead.
Okay. Good evening from Ghana, and thanks for this opportunity. I'm Abdul-Razak Issah from Ghana. I'm working with the Fountain of Blessings for Nations. It's a non-governmental based organization in Ghana. My topic has to do with assessing community members' level of knowledge about malaria and its preventive measures in the Bolgatanga municipality. The study really looked at the assessing community members' understanding of malaria and its related preventive measures. It was a cross-sectional study that was carried out in 9 endemic selected communities in the Bolgatanga municipality. Data was collected from 204 to analyze through the use of simple frequencies, percentages, and graphs. Malaria is an endemic in the Bolgatanga municipality that necessitated this study as part of my thesis from the University of Kwame Nkrumah University of Science and Technology. The outcome of the study revealed that more than half of the respondents believe that malaria could be prevented from the use of long insecticide nets, a feeling of stagnant water, and removing waste around the house were also suggested to be avenues that malaria could be reduced. The incidence of malaria could be reduced. The study recommends that public education should focus on cultivating evidence-based malaria eradication knowledge. It also recommended that government and non-governmental organizations, local stakeholders, and community members should interact more effectively so that knowledge and information will trigger for people to have the understanding of prevented through following the malaria eradication protocols. It further recommends that the use of radio community health volunteers and healthcare providers were found to be successful in channeling the malaria information and knowledge to people. So basically, this was what the outcome of the study. So my email address is below the abstract, which is razakis2002@gmail.com. So if you have questions, you can ask me.
Thank you very much, Abdul. I'm glad your connectivity prevailed, so we were able to hear this. I had a question, which was, are there any prevention techniques that are being deployed that this study demonstrated people were not aware of or not confident in that suggested there's a response that could be taken?
Yes, initially we realized that the community members were in regards to the use of behavior change communication. The use of behavior change communication is a tool that we can apply to change the cultural and the cultural status of the people, because we need to change their status quo, their mentality towards malaria. They don't believe that malaria is being gotten from the bite of mosquitoes. So with the use of behavior change communication,
I think we may have lost Abdul. We'll probably give him another 10 seconds and hope that his connectivity comes back. Okay, unfortunately, it looks like we lost Abdul, but I'll move us on to our next presenter. Renaud Jadakrim is from the Al-Qura University School of Medicine in the Kingdom of Saudi Arabia. So Renad will be presenting two posters, and we'll start with this one. So please go ahead, Renad.
Thank you, Annie. So I will start with the first poster. They both utilize data from the same project, and I will give a brief context about the project. The United Kingdom's Department of International Health Development, DIVID, funded the Access to Primary Healthcare Project, the ASSP project, from 2000 2014 to 2017 across 4 provinces in the Democratic Republic of the Congo, the DRC. The provinces are the Northern Sadabangi, Menima, and Tishobo. ASSB aimed to improve maternal and child health-centered outcomes through extensive integrated health system strengthening interventions. This paper, the first one, aimed to measure the impact of the project on intermittent preventive treatment with sulfadoxine permethrin, IPTP SP, uptake at antenatal care visits by comparing ASSP to non-ASSP assisted health zone in 2014 to 2017 among pregnant women. IPTP in the study was defined as the percentage of reproductive age women who were at risk of malaria and received at least 1 or more, 2 or more, 3 or more sulfadoxine permethrin doses for prevention of malaria at their most recent pregnancy, which resulted in a live birth within the 2 previous years preceding the surveys at antenatal care visits. A quasi-experimental community-level panel design with intervention and match control health areas and villages used as the unit of randomization and women as the unit of analysis was implemented to evaluate the project impact. A cross-sectional household survey was used to collect data in 2014 and 2017. Differences approach for measuring the impact of the project overall and across different subgroups was implemented. Even though that there was no impact for the project detected in the study, yet the uptake of all doses increased over time in intervention areas, with interesting findings that were observed for the uptake of 2 or more doses of sulfadoxine permethrin that are suggestive of potential masked impact for the project on this uptake. As we can see in this slide, among intervention areas, which is represented by the red line in the right graphs, the uptake of 2 or more doses showed the steepest slope increase in the predicted probability of this outcome. And also it was the only outcome that significantly increased and changed over time in intervention areas. Overall, the ASSP project impact evaluation research is the first to rigorously evaluate similar projects within the DRC context, and finding can help finding future strategies about and enhancing future strategies about antenatal care access, IPTP uptake coverage, and uptake in the DRC and countries of low income with compatible context. Thank you.
Thank you, Renad. Any questions about this first work that Renad's presented? Okay, perhaps we'll yield the time for these questions to your next presentation, and people may feel free to ask questions about this presentation after you present the subsequent work. So please take it away again.
Okay, so I move to the next slide.
Yes. Are you seeing the next slide? I'm hoping.
Yes, I'm seeing it. Thank you. So the second paper, which is determinant of malaria infection among children under 5 in the Democratic of the DRC. Malaria is the leading cause of death among children under 5 in the DRC, with around 26,000 annual deaths among these children attributed to the intense malaria transmission on the country. The second paper aimed to examine malaria infection determinant among children aged between 6 to 59 months in 2017 across the same 4 provinces in the DRC from my first paper. Malaria case in the study was defined as the occurrence of any malaria species infection in the child aging between 6 to 59 months, in whom malaria presence was confirmed using rapid diagnostic test, and only household with de facto children were included to be able to assess some determinant like using midnight overnight before the survey. The night before the survey. Also, parasite prevalence categorized per health zone of residence were estimated among all surveyed children aging between 1 to 59 months. Our method implemented a cross-sectional household survey data from 2017 collected for the ASSP project impact evaluation, pooled regardless the allocation to an intervention or control health zone. Children were the unit of analysis for the study. A multivariable logistic regression model was implemented to assess the association between the outcome and plausible underlying individual, household, and intervention and environmental determinant of malaria. Household GPS coordinates were used to estimate the vegetation index and total monthly rainfall within a 2-kilometer buffer zone of 1, 2, and 3 month lags before the survey visits. Our results showed that the mean parasite prevalence was 48% among all of the 4,472 surveyed children, with highest prevalence observed in the central area of Tishobo. Yet an overall heterogeneity in prevalence was observed among our surveyed children. Regarding malaria determinant, 2,530 children were RDT tested, with 52% of them were positive for malaria. Among positive malaria cases, children, majority were from rural areas, 55% were from the Manima Tishobo provinces, 71% lived in a household that owned at least one bednet, yet only 48% of them used that bednet overnight. Overall, from a descriptive analysis, heavy rainfall and vegetation index around our study areas existed throughout the study time. Regarding malaria determinants, odds of malaria were higher among children who are residing in the Manima Tishobo central provinces and who are residing nearby heavily dense rainforest, and an ascending trend with the child age was observed with malaria odds. An increasing malaria risk. In conclusion, finding of this study could inform planning and distribution of malaria resources, with giving priority for those children who are owning a higher odds and risk of malaria, and determining of the observed gap between owning a bednet and not using it, understanding the causes and determinant of the high odds and prevalence in the central provinces, and causes of heterogeneity in prevalences. From this study, it has multiple implications to understand the specific needs of the studied areas and to give priority for children of higher risk. Future research in the DRC is needed to understand determinant of the gap noticed between owning a bednet and not using it, and reasons for high prevalence and odds of infection in the central provinces of the countries, and the heterogeneity is absorbed in that prevalence across the studied areas. And I acknowledged my partners.
Great. Thank you.
Welcome.
Are there any questions for Renad? We have about 2 minutes, so we can probably field 2 questions.
I could ask a question, Annie.
Please go ahead.
Renad, thank you. I know that's a challenging setting to conduct malaria research in, so congratulations on that. I was just curious, over what time period were the cross-sectional surveys conducted, and at what time part of the year? Were they conducted during a high or low malaria transmission season, or spanning those?
So thank you, Dr. Bill. So there was a baseline survey that was conducted in 2014, and another one, a household survey that was conducted in 2017. Also, there was a health facility and a health worker surveys that I didn't include here. So the survey for the 2017 that I used for the malaria determinant was during July until September month. And across my studied areas, it was a rainy season all over the area, except for the areas below the equator in Manima. That's why, to account for that seasonal variation, I used SHRPS data and NASA vegetation index data to see how that variation across the studies areas predicted the odds of malaria. I created variables for 1, 2, and 3 month lag per each survey visits, and I assessed these lags for vegetation and for rainfall, which one is best fitting my model, and I found that vegetation index at 2 month lag was the best fitted, and it was the strongest determinant of malaria, residing near highly dense rainforest. It's the strongest determinant that predicted higher odds for malaria infection in the children.
Great, thank you.
Welcome.
Renad, I actually had a question about the NDVI and rainfall construction as well. How did you decide on the 2-kilometer buffer? You mentioned the lag was based on which had the strongest relationship, but how did you pick 2 kilometers?
So I used the DHS geospatial manual where they recommended, and also the literature. There has been a usage of either a 2-kilometer buffer or 10-kilometer buffer zone around the household GPS coordinate to account for the mobility of the host and the vector for malaria infectivity. And for the vectors that we have in the DRC, 2-kilometer buffer zone do cover their flight range.
Okay, great. Thank you. That's something that
Welcome.
I've thought about in Zambia quite a bit as well. So it's helpful to hear that.
The DHS sometimes used it 2 kilometer versus 10 kilometer versus, depending on urban versus rural setting. But for us in this study, we decided to do it based on the flight range of our main vectors.
Great. Thank you very much. So that's the conclusion of our lightning talks today. I have just put a message in the chat. A few speakers have asked me, or a few attendees have asked about speaker contact details. And I know many of you have included those on the slides, but if you'd like to put it in the chat as well, I know that others would appreciate further contact about some of this work. So I'll leave this, and please make sure to message the full group if you'd like to, rather than direct messaging me. But feel free to do that if you'd like. So we are at the end of our program. Thank you all for attending both this lightning talk session. Thank you to all of our presenters and the collaborators that you've worked with in coming to this work and sharing it with all of us today. And we are at the end of the program for the World Malaria Day program. So we thank you for your attendance. We know that depending on where you are, it's morning, afternoon, or evening. So we're fortunate to be able to gather in this virtual setting and enable more of us to come together. I'll leave the chat open for another minute or so people can put in any last messages. But that concludes our session today. So thank you all very much and have a great rest of your days and weeks.